name is Brittany Williams, a registered nurse and a Doctor of Nursing practice student. I am pleased to speak to you today about the importance of quality of life for terminally ill individuals. Quality of life reflects overall enjoyment of life, sense of well-being, freedom from disease symptoms, comfort, and the ability to pursue daily activities. Health-related quality of life includes mental, physical, emotional, and social functioning. It focuses on the impact that health status has on quality of life. Well-being, which assesses the positive aspects of a person's life, is a concept that is often related to health-related quality of life. Healthy People 2020 emphasizes the significance of health-related quality of life and well-being, characterizing it as one of Healthy People 2020 4 foundation health measures. Health-related quality of life is measured through 3 domains, including self-rated physical and mental health, overall well-being, and participation in society. Self-rated physical and mental health is measured through a subjective assessment of one's health. Well-being measures assess the positive evaluations of one's daily life to include satisfaction and positive emotions. Participation measures reflect one's assessment of the impact of their health on their social participation within their environment. When one or more of these domains is affected, health-related quality of life is also impacted. Health-related quality of life is determined by the nature of the person's experiences and the values attached to those experiences. It varies for everyone, making it an individualized, subjective evaluation of one's health and well-being. It is imperative that you acknowledge the significance of health-related quality of life for all people, including those who are dying. When individuals suffering with terminal illnesses have a negative perception of health-related quality of life related to symptom distress or impaired physical and mental function, they should be given the freedom of choice for end-of-life decisions. Common end-of-life concerns include loss of autonomy, limited ability to engage in enjoyable activities, and loss of dignity. Dignity is an essential component of quality of life as it provides individuals with a sense of value and self-worth. As a healthcare professional, I urge you to support Death with Dignity Bill 697 to allow all individuals residing in the United States the right to a dignified end-of-life plan.
Good morning. My name is Anita Fligge, a registered nurse and Doctor of Nursing practice candidate, and also a resident of California. Thank you for allowing me to speak here today. Death with Dignity is an end-of-life option that allows eligible patients to voluntarily and legally request and obtain medications to end their lives in a peaceful, humane, and dignified manner. Death with Dignity should be afforded to all qualified individuals, not those terminally ill who reside in Oregon, Washington, Vermont, California, Colorado, and District of Columbia. Offering terminally ill patients who meet strict criteria of a dignified death at the time of their choosing should not be limited to these states only. You might remember Brittany Maynard, who had terminal brain cancer. She and her husband moved to Oregon from California for her to be allowed the opportunity to die with dignity. Under federal law, no one will have to take up legal residence in another state to be allowed that freedom of choice. It is understandable that there is angst around allowing people to hasten their death. The current Death with Dignity Acts have strict criteria in place to allay those fears. To qualify for a prescription of medication, one must be an adult resident of the aforementioned states, mentally competent, capable of making and communicating one's own healthcare decisions, diagnosed with a terminal illness that will lead to death within 6 months, and able to self-administer and adjust the prescribed medication. Additionally, 2 physicians determine whether all of these criteria have been met. The process involves 2 oral requests, minimally 15 days apart, 1 written request, and a 48-hour waiting period to fill their prescription. There are no exceptions, and the process will be stopped immediately if there is suspicion of coercion. Oregon Public Health Division just released their 2016 summary. 204 people received prescriptions. As of January 23, 2017, 133 people had died in 2016 from taking the prescribed medications, and that includes 19 who received prescriptions from previous years. Of those patients, 80.5% were aged 60 years or older with a median age of 73, and 78.9% had a diagnosis of cancer. No referrals were made to the Oregon Medical Board for failure to comply with requirements of the Act. If diagnosed with a terminal illness, I, as a California resident, have the choice to set the time frame of my death. That gives me a sense of freedom and empowerment. I may never choose to take the medication. In fact, about 1 in 3 people never do. but knowing that I have that option gives me comfort and peace of mind. All Americans should be afforded the same opportunity. I strongly urge you to support Death with Dignity Bill 697. Thank you for your time.
Good morning. It is both an honor and a privilege to be speaking with you today. My name is Pam Smith, and I come before you today as both a healthcare provider and a registered nurse to remind this Congress that we are charged equally with protecting both the quality of one's life and promoting death in one's dignity. Death is an inevitable part of an individual's life. Unfortunately, because of cultural differences, death has become taboo in Western medicine. Currently, only 5 states and the District of Columbia allow for some sort of assisted death process. It is this team's specific recommendation that Bill Death with Dignity 697 be passed. Death with Dignity 697 will allow for preparatory arrangements to be made both well in advance of the end of life and at life's final moments. The facts here are clear. Elder care expenses exceed $120 billion per year, and Medicaid currently foots the bill for 44% of that, and fewer than 1% of patients have clear end-of-life plans. We need to act now. In addition, it should be noted, despite state-of-the-art palliative care measures, a small group of patients remain in excruciating pain. Choice and autonomy seem to be the presiding themes in this process. Providing choice over one's dying relieves apprehension and provides some measure of control and comfort. This request is not exclusive to those who are elder. It would and should include those who suffer from an incurable disease and wish to choose how they die. The legally determined threshold will be as follows. Those suffering from an incurable disease, where the suffering is uncontrolled by all palliative care measures, the patient must freely ask for relief from the suffering. Patient judgment is not distorted by physiological or psychological conditions. The decision is made in context with a meaningful physician relationship. A final decision will be reached after a second physician is consulted and a waiting period of 2 weeks has elapsed. The individual can take the medications unassisted. Clear documentations of all steps have been accomplished. I urge this body to act immediately to protect the right to die. It is an unalienable right as that to live. By adding medically assisted deaths to the current legislature, we can continue to support the Supreme Court's 1997 decision that states, obtaining medication to alleviate suffering even to the point of unconsciousness and hastening death is legally acceptable. Your support for Death with Dignity is both expected and appreciated as we continue to provide compassionate and dignified care both in life and in death. Thank you.
Good morning. My name is Teresa Crowder, and I am an advanced practice nurse licensed in Virginia as a clinical nurse specialist, and I am a doctor of nursing practice student. Today I'm going to talk to you about the healthcare team in regard to fictitious bill number 697, Death with Dignity. Death with Dignity must include a relationship with a person's primary care provider. Currently in our healthcare environment, this primary care provider can be a medical doctor or a nurse practitioner. Bill number 697 is unique in that it includes the nurse practitioner as a member of the healthcare team actively participating in and prescribing medications to allow death with dignity when requested by their patient. Our current healthcare system is not meeting the needs of patients at end of life. When end of life care is not appropriate, there will be a decrease in the quality of a person's remaining life. Death with dignity means a person can legally obtain prescription medications that will end their life in a peaceful and dignified manner when the patient chooses. There needs to be an end-of-life discussion between the patient and the primary care provider in person and as soon as possible, ideally when the patient is feeling well. This discussion needs to be documented. The person's wishes are to be made clear at this time, and this is made easier when there is a relationship between the person and their healthcare provider. Nurse practitioners have an ongoing relationship with their patients as they are currently providing routine health care in a variety of patient settings, and the patient should be allowed to continue this relationship when discussing death with dignity. Bill number 697 will allow this relationship to continue. Advanced practice nurses are important members of the healthcare team. There are over 222 licensed nurse practitioners in the United States. Nurse practitioners are integral in providing high-quality, patient-centered care. Nurse practitioners focus on health promotion, health education, and counseling of their patients. Nurse practitioners already have important conversations with their patients. Millions of Americans receive their health care from nurse practitioners when there are no other health care team members available, especially in our rural and underserved areas. There are currently 20 states that allow nurse practitioners full practice authority. Full practice authority means nurse practitioners can practice as they were educated. They're able to evaluate, diagnose, order and interpret diagnostic tests, and they can prescribe medications under the guidance of their state board of nursing. Nurse practitioners must be included as a member of the healthcare team in Bill number 697. Thank you for your time today. I am asking for your support of Bill number 697, Death with Dignity.
Good morning. My name is Kathy Colbert. I'm a registered nurse, Doctor of Nursing Practice candidate, and advocate of Death with Dignity Bill 697. In 2014, traditional Medicare spending averaged $34,529 per beneficiary in the last year of life, almost 4 times higher than the average cost per capita for seniors who did not die within the year. In fact, approximately half of Medicare spending accounts for hospital inpatient expenses for people in their last year of life, while hospice, which allows for end-of-life care in the home, accounts for only about 10% of Medicare spending. In spite of the fact that 90% of adults prefer to receive end-of-life care in their home if they're terminally ill, the data shows that only about 1/3 of elderly Medicare beneficiaries age 65 or older die at home. As you've heard today, Death with Dignity Bill 697 will provide Americans with freedom of choice and control at the end of life. In January 2016, provisions of the Accountable Care Act were initiated to improve funding for health care in the last 6 months of life. However, current legislation, including Medicare and Medicaid, does not provide funding of medications prescribed under death and dying statutes. The cost varies based on the type of availability of the medication prescribed, as well as the protocol that's used. The average medication cost of $400 to $600 per beneficiary is insignificant compared to the cost of health care, particularly in the last year of life. This bill embodies the Supreme Court's 1997 decision that states obtaining medications to alleviate suffering, even to the point of unconsciousness and hastening death, is legally acceptable. Additionally, the Henry J. Kaiser Family Foundation reports that Medicare spending during the year of death decreases with age after age 73, suggesting that patients, families, and providers may be opting for less expensive and less costly end-of-life interventions for beneficiaries as they grow older. This bill proposes Americans throughout the United States be provided the benefits of Death with Dignity legislation. Additionally, it incorporates the Institute of Medicine recommendations for improving end-of-life quality of care, comprehensive coverage for patients with advanced serious illnesses who are nearing the end of life, and the patient's right to choose their own treatment plan. I urge Congress to support Death with Dying Bill 697 and ensure the right to die with dignity for all Americans. Thank you for your time today. If you have any questions or concerns, I would appreciate the opportunity to discuss this bill further. Thank you.